today's topic? Make sure to subscribe to the Medsplaining podcast on your favorite podcast platform to never miss an episode. Welcome to a very special episode of Medsplaining. My guest today is a fellow certified menopause provider, Jessica Bawden. Jessica is a nurse practitioner at Women's College Hospital here in Toronto. She's been with the team there for over 13 years, all of which she has spent caring for women across the reproductive spectrum. She has a background in labor and delivery, lactation consultation, well baby care, and mature women's health. To say she's well-versed in the issues surrounding women's health is an understatement. Today, Jessie and I will delve into the personal impact of the menopause transition on patients, the shortcomings of the Canadian healthcare system in providing access to care, and our own approaches to managing the dozens of symptoms that we encounter in our practices. The episode today was made possible thanks to an education grant from Bayer Canada. One of the aspects we'll talk about today is the crisis in family and primary care. So about 6.5 million people in Ontario don't have a family doctor at present, and Jessie works with a large team of family doctors who are really feeling the brunt of this crisis. So while menopause is having a big moment and a lot of women are hoping to seek care from their primary care providers, we know that the education system for doctors has not kept pace with the needs of women in menopause. And this is part of what's leading to this crisis. So family doctors are doing their very best out there to provide all of the care in all of the various aspects of people's lives that they can. But this is one area where even family doctors are feeling they're being failed by the system. So we're hoping to shed a little more light on that today. Jessie, thank you so much for being here. I've been really excited to have this conversation today, but before we delve into sort of the medical stuff, tell us a little bit about yourself.
Yeah, for sure. Thank you so much for having me. I'm so pleased to be here. My name is Jessie Bawden, or Jessica, whichever you prefer, but I am a nurse practitioner in primary health care. I work at the academic family health team at Women's College Hospital, where I perform, primary health care for all ages. Always had a special interest, and then what followed was specialized training in women's health. So I like to joke that as I've gotten older, I've sort of filled my basket with the skills to deal with the women's health issues that I'm going through and my friends are going through. So started with labor and delivery, and then I was a lactation consultant. I do a lot of sexual health and now menopause care.
Awesome. Mm-hmm. And I did a lot of my training at Women's Family Health Team. So because I was a Sunnybrook resident and we were partnered with them. So
yes.
So that's... Yeah, I've spent a lot of time there too, so it's great. The doctors there are wonderful. Mm-hmm. So as a nurse practitioner, what would the patient's journey be like to get to see you, and where does it go from there?
Yeah, so all of our patients at the family health team are assigned to a physician, rostered to a physician, and then we have nurse practitioners that can help with access if the physician is not available, or if the care that they need is more specific to the training that we have. So I'm very lucky that I work with another NP, Lauren, who is also very skilled in women's health. And over the years, we've really kind of honed this subspecialty. So we offer women's health procedures like IUD insertions and endometrial biopsies, along with, of course, cervical cancer screening. So if you're a patient at our family health team, you may see me because your doctor is not available or because your physician has asked for you to see me for a particular reason. I also do a fair bit of same day, next day availability. So if you have an acute or episodic issue, you might see me for that reason as well.
Okay.
I think that the menopause care, though, in particular that I provide is similar to what you might receive from any menopause certified clinician. The scope of practice of NPs is quite close to that of a family doctor. And when it comes to menopause care, there's actually no real limitations in what we can do. So I think, if you're fortunate enough to be a family health team member of ours, you could see me for menopause care.
That's fantastic.
Mm-hmm.
And so what would you say, in terms of symptoms, would you say are sort of the top 5 that you would typically see women coming to seek care for?
Yeah, great question. So a lot of it is just irregular bleeding. What is happening? Sometimes it's heavy menstrual bleeding that needs to be tweezed out as to whether this is normal within the menopause transition or it requires workup. But the classic vasomotor symptoms are often what do bring women in. So hot flashes that are really bothersome, disrupting their ability to sleep or to work and to sort of like function as they have always.
Right.
And then, so yeah, the vasomotor symptoms, those hot flashes, those night sweats. And then I do see a lot of women just complaining of just not feeling like themselves, right? So whether that's because their sleep is disrupted or they have some cognitive concerns about brain fog, or they're feeling a little bit less sharp, a little bit less able to handle the things that they've always been able to handle with such grace and ease. So yeah, vasomotor, sleep, brain fog, and then that irregular bleeding probably.
Okay.
Yeah.
Do you find the conversation is changing around menopause?
I think so. I think, people say it all the time, menopause is having a moment. I think that's probably true. I think that it's probably also due to just women being more empowered generally as like equity and equality has changed over the years. So yeah, I think women are asking for help. And I hope that uptick in their demand for care is increasing our clinicians to get trained up as well, and be able to answer the questions. And if they can't answer the questions, women need to know that somebody probably can, so to keep pushing forward. Yeah.
Do you feel that's happening? Do you see more providers trying to educate themselves, or at least seeing the impact that what you're doing is having on their patients?
I do. I think that we're at this is a whole nother podcast. I think we're in a really difficult time right now to expect primary care providers in particular to do more of anything. We're really at a real crossroads right now with the ability of primary care providers to meet the needs of patients in a safe way that's timely and all of that. So that's a bigger conversation. But I do think, and I'm encouraged by the fact that, Health Quality Ontario is about to come out with a huge practice standard on how to provide menopause care. And this is the first of its kind. The RNAO that has sort of best practice guidelines has come out with one on menopause. And there's planning tables that I've sat at both of those planning tables, and there's others that continue. A lot more philanthropy is happening in the area of menopause.
Yeah.
And as a result, we are seeing more residents and more learners. I am personally seeing more residents ask to spend time with me, right? They want to be exposed because, unfortunately, the curriculum hasn't quite caught up. So it is up to the clinicians to get that experiential learning and to seek those opportunities to learn and be able to do the care independently.
Right, because it's really not incentivized.
Unfortunately not. I think
we're sort of self-funded when we become menopause experts.
Yeah, I don't bill OHIP personally, but I do know that unless you're working in a setting as a nurse practitioner where you're given kind of the freedom to carve your own clinics, I think it would be very hard to have enough time to do good menopause care, even as an NP, if you're seeing, lots and lots of patients for acute episodic or chronic disease management or whatever it is that the role dictates. So I feel fortunate that I have a bit of a subspecialty in this area, and I've got the time to spend with patients. But for family doctors, it's, the time to spend is great, and it often requires multiple appointments in order to find the best treatment plan for women.
Exactly.
And so, the way our healthcare system is set up, it does make it really difficult to provide comprehensive menopause care.
It does. And also, what I mean by incentivized, we're self-funded in the sense that I know everything I learned was through courses that I paid for, that I sought out, webinars that I attended, conferences that I attended, hours and hours and many dollars spent acquiring the skills to become a menopause practitioner. And so that's something that like a nurse or a physician would have to, and then you have to pay for and write the exam, right?
Yeah.
So it's something you have to
really want to do
and then have the time to do.
Yeah, exactly.
So I think that's also why we're seeing just such a lack of care in this area. And then, women are often dismissed by doctors because they don't know what to do. I remember the sense of panic I used to get as a family doctor if someone wanted to talk about their menopause symptoms, because I actually literally had no toolkit to approach this with. I didn't understand it. And so I would dismiss it. I wouldn't tell them this, but a lot of women are told it's all in your head. And so let's talk about that, because it's sort of it sort of is in your head. A lot of these symptoms originate in the brain.
Yeah, absolutely.
So what do you tell patients about that aspect of it?
Yeah, I mean, I think that it still continues that women are dismissed, right? They're told that their symptoms, just hang on, it'll be over soon.
Yeah.
And like in actuality, sometimes women are suffering with menopause symptoms for up to 10 years. And they're not only dismissed by their family doctors or by people in the healthcare system, they're dismissed by their managers, their employers, their friends, their family, their partners, right? It's like, oh, it's just menopause, like, oh, hysterical woman. But I mean, this can be really bothersome. And I found one of the stats from the Menopause Foundation study that I found so poignant was that, 1 in 10 women will forgo a promotion or leave the workplace entirely because they're not coping during the menopause transition. So it's all in your head. It's kind of a catch. Is that called a catch-22? Where, so many of the symptoms do originate in the brain. Got sort of, we can talk about the mumbo jumbo of the HPO axis and all of that stuff, but we've got the hot flashes originate in the brain, insomnia, mood, and how we manage just in general. It has so much to do with how we interpret the stimuli in our world. Yeah, so it is all in our head, actually.
Well, and speaking of that, I was fascinated to learn that it wasn't until 2008 that they actually discovered what causes hot flashes.
Yeah, it's so fascinating. I remember going to the menopause, the Mature Women's Health conferences at Mount Sinai, and they were talking about these candy neurons and the neurokinin and all the different neurotransmitters and thinking like, wow, that's the future, right? And like the future's actually now.
So the candy neurons, for anyone who doesn't know, these are these neurons in the thermoregulatory center in our brain. So this is the part of our brain that's like the thermostat, right? Yep. And so scientists discovered in around 2008 or so that these neurons get important feedback from estrogen. And so when estrogen declines, those neurons hypertrophy. They get bigger, they get more sensitive, they're misfiring, and they're misinterpreting the temperature around us and within us. And this is what causes the brain to misinterpret the temperature and lead to a hot flash.
Yeah.
And so this has led to innovative new ways of managing hot flashes, which is so important. I mean, first of all, it explains why estrogen helps for women who are able to have estrogen.
Yep. But then estrogen receptors are all over our body. Right. So, I mean, it's fascinating. And to think that there's this new class of medications, which is targeting that pathway and kind of telling those candy neurons to settle down and blocking that signal. And it's considered a non-hormonal class of medicines,
right?
Which is also very helpful, as we know that estrogen is not for everyone.
Right.
And that's one of the decisions that we need to make when we're hearing about a woman's situation is, would estrogen help her, or should we try something different?
Exactly. And knowing who's a candidate and who isn't a candidate can also be confusing because a lot of women are told sort of mythology around not a candidate, like you had someone in your family history who had breast cancer. I used to believe that. That was never in the guidelines. That was never a thing.
Or that estrogen is dangerous.
Right, exactly. Right? So when you say, menopause is isn't a movement or having a moment, it's more like a course correction, in my opinion, because even the things we were taught were so misguided, were so incorrect or over exaggerated. And so I know we kind of I asked you because there was this trend online about a lot of menopause practitioners were going on and sort of having like a mea culpa, they're apologizing for the terrible provider they used to be.
Yeah.
And you've been doing this a really long time. So you're like, that didn't really resonate with you. It definitely resonated with me because I think when I came out of residency, I had never seen anyone on hormone therapy.
Yeah.
I never had the opportunity to renew it, to see the impact that it would have on a woman.
Yeah.
And so much of what we learn is from what the patients tell us.
Yeah.
So I would love to hear some sort of standout success stories that you've had. Like, what are some of the ways that you have seen treatment, either hormonal or non-hormonal or some combination, impact a woman, maybe help her from being one of that 1 in 10?
Yeah, absolutely. Oh, I have such a good story with that 1 in 10. So I had a woman in her early 50s who came to me with, I'm not thinking straight. I can't, I'm screwing up at work. I'm missing deadlines. I'm slow. My boss is noticing, right? I'm just not as effective as I used to be. And I need help. Like something's wrong with me. Something's wrong with me. What's wrong with my brain? So got to talking with her. And so she was one of these women that her primary concern, her big reason for seeking care was maybe the cognitive, the brain fog, whether or not there was some attention lacking or motivation or, and historically this woman might have been diagnosed with her first major depressive episode or her first like generalized anxiety disorder, right? Like she may have been diagnosed, and like this is how the care is changing, I think, because with further questioning, turns out that she's having like a few night sweats per night, right? She's up in the night and her sleep is disrupted. And then she did have some hot flashes, although she doesn't describe them as too bothersome, but some, right? Yeah. Enough that she may worry a little bit more when she's in a meeting that she's going to have a hot flash, or take a little bit longer to get dressed and then like be rushing, and like it was impacting just sort of how she runs the day. Right. So we decided to start estrogen and progesterone therapy. I had her back for her 4-month follow-up, and she said, "You'll never guess what's happened." And I was like, "What has happened?" She's like, I haven't had a hot flash since I started it. I'm sleeping through the night. I feel great. And I have so much less social anxiety about not messing up, not knowing what to say, saying something dumb. All of this social anxiety has gone down that I'm seeing friends more. I'm putting my hand up for presentations and doing things more at work. I'm more effective at work, but also I'm not drinking as much. And I was like, "You're not drinking as much?" She's like, "I realized that every time I'd have to go," she's in the type of business where she needs to go and schmooze with people. She would have a number of glasses of wine many times per week. Yeah. She's like, "I don't need it anymore. I'm sharp as a tack. I don't need to dull and be silly and funny and take the edge off with alcohol." And so as a result of estrogen and progesterone therapy, I've decreased her risk of breast cancer, her risk of colon cancer, decreased her cardiovascular risk factors, and of course her chances of like liver problems. Like the impact was so much greater than what we were going for. And it was just like, I was just like, this is so great. And I think that until you start doing the care as like a novice clinician, maybe who's still learning, like once you start doing it and you start seeing these outcomes, that builds your confidence to do it more, right? And so even though sometimes the prescribing seems like confusing, there's this and that, and there's a little bit of this and a little bit of that, and the patch and the pill and the da-da-da, what do I choose? Once you find like your go-tos, and you see the patients have such improvement, like you'll know to keep going, right? So it's just a matter of getting started, I think.
Yeah, I think when I started, I was putting a lot of people just on the regimens that I was the most comfortable with, or frankly, what was available at the time, because this is an area of care that's plagued with back orders and medications temporarily being out of stock and stuff like that. Yeah, I would say just try. Just use something that you feel comfortable prescribing and build up your toolkit. It's okay. I've learned as I've gone, and this is an evolving field of care too, right? We're always learning new things.
Yep. Yeah, and thank goodness, the Ontario drug benefit is not perfect, but we have seen some movement with respect to what is covered. So for people on ODSP or OW, or if they're over 65, we've got lots more options than we did even 5 years ago. Yep. So it's good. It's starting to change.
Yeah, that is fantastic, because that's always been a barrier to access for women. Sure. But there are things available. You need to just go out there and ask. And even for heavy bleeding, there are certain things we've talked about, like IUDs and things that they have programs to get you an IUD for low cost or no cost if you need it, even if you don't have a drug plan. So
absolutely,
just ask. You'll be pleasantly surprised at what might be available out there to help you. You don't have to suffer in silence. That's for sure.
I always say, like, menopause is normal, but suffering is not, right?
Exactly.
Maybe I'm not the only one that
No, exactly. And it shouldn't have a sliding scale. Like, it's not up to your doctor to decide how much you should suffer. We don't have a sliding scale for erectile dysfunction.
Can you imagine?
Like, well, how bad is it?
Yeah,
Oh, you have
yeah.
one erection, you're fine.
Yeah, exactly. 1 hot flash, 10 hot flashes. Like if it's bothering you, we should help.
Yes,
her.
and don't you find women compare?
Mm-hmm.
Like they'll
I'm
come
not
and
that bad
they'll
as my friend, right?
Exactly.
Yeah.
They'll downplay it because they see what's in the movies, right? Or they hear from their friends. Like if you're not soaking the sheets every night, that can't possibly be bad enough to warrant seeking some care for this.
I mean, the only reason I ask women to quantify that sort of stuff is so that I can, when I see them back and they're 90% improved, I can say, remember you were having 10 a week, or maybe you're having 10 a month or 10 a day. Now it's 1. Yeah. Right? Or 2.
Well, because I find they lose track of their baseline.
Yeah.
So it's true because it's like we remember the bad things. It's like Google reviews, right? Like you tend to go on and review something if you're really unhappy, but if you're actually enjoyed something, you're not as motivated.
Yeah.
I feel like it's a little bit of that. We kind of tend to forget all that stuff. Like once we're feeling better, we're just kind of living in that moment.
Yeah, for sure.
And
So
not
taking a
dwelling
good
on it.
history and documenting where she's at baseline.
Yeah.
Actually, it's really helpful. And so one thing women can just start to do even before they go seek care is to keep some good records. So there's many, many free apps where you can track your period, but also track your symptoms like headaches and sleep and brain fog and mood and all of that stuff. It's good data to bring to your family doctor.
Either track symptoms, understand their symptoms, understand various treatments that are available, or to seek services of a provider.
The good news is that so much of the self-management is helpful for menopause and also for just general longevity and wellness, right? So the diet, the exercise, all the things that you've talked about on your podcast on other episodes also do help with menopause symptoms. So
They really do. And I think they all work in a complementary fashion. Like you said, if you're sleeping well, it's having incredible downstream effects on your daily performance. Your productivity, your mood, your energy levels, your ability to get out and get some fresh air and move your body. And these are all the things that are important.
Yeah.
Do you find you're doing a lot of lifestyle counseling, or that women are coming to you with weight concerns, dietary concerns, confusion about what to believe?
I think like dispelling some of the myths, like I do think it's important we remember that not everything is menopause, right? And menopause hormone therapy isn't going to fix everything. So although the pendulum has swung away from, menopause doesn't exist to menopause is everything, I think we're still we're going to find it settle. So, I mean, the good news is that the lifestyle counseling, everything needs to be women need to think about, using the old SMART goals, right? So if we ask women to change their diet, is that culturally appropriate for them? Is that economically possible for them? Like we have to think about, and that's why, I think menopause care is primary care. We know the patients, we know their families, their background, what they do for a living, what they've been through. And so to make recommendations that actually are doable and attainable for people, I think that's the value of knowing people across the lifespan.
I think that's a really important point. And so often I find women are given vague advice when it comes to the lifestyle component.
150 minutes of exercise. It's like, what?
How? What does that mean? And how do I start? And and does it have to be all or nothing?
Yeah.
I'd rather someone do 20 minutes than 0 minutes. Like if 150 is not attainable for them in that moment, like I think these are aspirational goals.
Yeah.
But you have to just put the running shoes on first.
Yeah, 100%.
And I try not to ask people to do something I'm not doing myself, or that I can't fit in to my schedule myself, or that I'm not realistically going to be able to follow myself. Because I think that's just unfair, and it makes people feel like it's more of it is their fault.
Yeah.
They can't live up to these ideal standards of exercise or nutrition.
Yeah, absolutely. It's a very isolating time, right? We've got women are kind of we're in this sandwich generation right now, and in your 40s in particular, and early 50s, you've got, you had your children perhaps a little bit later, so now you've got all these teenagers, and you've got aging parents, and you're at the height of your career. Like, this is probably not the time to ask women to do more. In fact, I think that that's really dismissive and even further isolates women. So working with women to figure out how we can peel away at what is the core underlying problem here, try to fix that, and hopefully we see sort of the domino effect on their motivation to be a little more active or to eat a little bit differently, and their ability to really rest and sleep without the rumination and the worry. So I think it's like, it's a whole person for sure.
And it takes time. These are things we build up to. It doesn't happen overnight. And I think the expectation that things should be instantly better is also going to lead to disappointment. So
I mean, shockingly, sometimes things are instantly better with
yes.
therapy.
I will always,
which is crazy.
I will always tell patients, here are some things. There's a short list of things.
There's like
do get better very quickly. But brain fog, for example. They'll often say at the follow-up, okay, but my brain fog is still, is still not fixed. How do you explain that to them? Like, what's your approach to helping them understand the mechanisms behind our brain fog?
I mean, I think that like the evidence is evolving around this, but what I think makes sense is that, during these perimenopausal years, so if you can imagine, you don't know when your final menstrual period is, but the 2 to 3 years before that happens, it's like the Wild West. So, your estrogen is all over the place and your brain is trying very hard to accommodate for these fluctuating levels of sex hormones. And so, the cognitive kind of fallout from that makes sense, that, are like and usually, I mean, what I've heard too is that the brain fog is usually a very short-lived symptom. It's usually right around the years around the final menstrual period. So I mean, I do encourage women that if we can improve their sleep and make sure we've ruled out iron deficiency anemia, like how many times are women coming in to say that they have these symptoms and no one does any blood work? It's like, come on, let's go back to basics, right?
Well, I think they're focused on getting hormonal blood work done. And we know that that's sort of not going to tell us much. But the things that will tell us something are you iron deficient?
What's your thyroid
What's your
doing?
thyroid doing?
How's your sugar?
Exactly. B12.
All
the B vitamins are all declining at midlife, and we're not really monitoring for that. We're not really measuring for that, and that can have a big impact on brain fog.
I know, and women say sometimes, is this OHIP covered? It's like, yes, this is a standard workup. As long as you're seeing a provider that is a regulated provider and has the scope to order blood work, like it's OHIP covered, of course.
And like you said, it's finding that sweet spot between menopause doesn't exist and everything is menopause. So
yes, I mean, recently a very good friend of mine was complaining of fluctuating mood, disrupted sleep, feeling extremely low energy, just walking around, moving through molasses. And, of course, you think, like, this is a new depression. This is a new, she's got the Siggy caps. Like, she ticks all the boxes, right?
I'll explain for anyone who doesn't know. That's this acronym for the symptoms of clinical depression.
So like sleep and interest and feeling guilty about how she can't keep up with her kids and all of the things. So, and I was like, did someone do your blood work? Turns out she's walking around with a ferritin of 5.
Oh, yeah. Okay.
No one's going to feel good with that,
No.
right? And we know now that, our iron stores need to be definitely above 50, as close to 100 as possible, in order to really have the energy that we need and the motivation and the get to it and the clear thoughts, and everything feels great when we're not starving for oxygen.
No kidding. So let's get into a bit more detail about how you might make a decision. So suppose your friend were to go see you. Suppose she's not your friend, so she comes to see you. And suppose it was not iron deficiency, or you've solved the iron deficiency, but she's still having all of these depressive symptoms and she's clearly in perimenopause. How would you go about deciding for this person what approach to take? Like, who might be a good candidate for hormone therapy versus an SSRI, SNRI, versus one of the new neurokinin receptor antagonists?
Yeah, very good question. Like, there's lots of literature that's tried to sort of algorithmically define how we move people down to a treatment protocol. And those can be really helpful. There's one on the MQ6 website, for example, which was developed by a family doctor here in Toronto, which is excellent.
Yeah.
And so one of the first questions that you're going to ask somebody is like, do they have hot flashes? So if they have hot flashes, night sweats, or what's called the genital urinary syndrome of menopause, where they've got vaginal dryness and perhaps frequent UTIs or painful intercourse, anything that's going on below the waist, and if they're open to estrogen therapy, estrogen is going to improve those symptoms. And that's the first line therapy according to all of the different societies. So we've got the Menopause Society, which is formerly known as the North American Menopause Society. We've got the Canadian Menopause Society, International Menopause Society. They all say the same thing. Yeah. First line therapy for those classic symptoms is estrogen therapy with or without progesterone if they have a uterus. So that's one arm, right?
Yeah.
But if someone would prefer not to take estrogen, or someone has a contraindication to estrogen, then we can look to those non-hormonal options. So SRIs, SNRIs, and a couple other medicines, gabapentin, oxybutynin, like they do help those classic menopause symptoms, but they also help other symptoms. So if someone comes to me and they don't have those classic vasomotor symptoms, GSM symptoms, but perhaps they're more on the mood or the sleep side of things, then you might even start with a non-hormonal medicine. So, first line therapy for someone with a mood disorder or an anxiety disorder would be an SSRI or an SNRI. So choosing one that's also known to help in menopause. So there's 4 or 5 of them, which at particular doses also help with hot flashes. So you kind of can go down these algorithms, and then the non-hormonal family that we were talking about now with respect to the neurokinin receptor antagonists, those ones are really going to help hot flashes, and they don't have any other sort of they're not necessarily going to help with mood. They may, depending on how we evolve this family of medicines over time. Yeah, so I think asking the patient their preference, certainly ruling in that it's a safe thing to use estrogen, and then deciding, if it's something also that they can afford to pay for.
Sure.
So that's also a consideration.
Yeah.
But I think these nuances of how you get down to the treatment protocol comes with experience, unfortunately. So I think that's why it's maybe a little bit scary for new clinicians to try these therapies. But bottom line, if they're appropriate for estrogen, estrogen is going to help them.
That's the thing. And even for mood symptoms, estrogen's an important modulator of serotonin, right? So sometimes women do find they'll try the SSRI, they'll try the SNRI, and then it's like, why isn't this working? And, maybe before ramping the dose up too high, you want to have that. You want to loop back and have that discussion again. I mean, the NICE guidelines out of the UK, for example, they now have actually MHT as a reasonable option first line for mood dysfunction it's exacerbated or starts at perimenopause. We want to make sure we're finding out, is there some underlying or long-standing depression or anxiety that's there. But when it's clearly brought about by the transition, it's reasonable. But that's where this nuance comes in, because you'd have to say to the patient, look, it's not in the guidelines here.
Yeah.
But we generally feel like there's expert consensus that it's safe.
Yeah.
We've seen it help many women. It is in guidelines in other parts of the world. We just don't have it yet. Although I know there's work being done now looking at hormone therapy as first line for the mood dysfunction.
Yeah, and I hope it's coming to Canada, because it is nice to be able to work within it not being off-label, but so much of what we do in medicine is off-label. So in fact, most NPs and physicians are very comfortable with using data and literature to guide their treatment protocol rather than just what's been Health Canada approved. But it's always it does give you so much more confidence in what you're doing to use medicines that are on label. So, yeah.
Do you feel hormone therapy is held to a higher standard than any other therapeutic options in medicine? I'm leading the witness a little here. I definitely do. I see these tiny risks that are made out to be massive, and I see it being withheld without justification from so many women.
Yeah.
And as primary care providers, we prescribe so many different medications. And for fun one night, I went down this wormhole of looking up lots of different medications and whether they had been conclusively linked to breast cancer, or if anyone had done a specific study to see if all of these different medications, and not hormones, like non-hormonal medications, had anyone proven that they weren't linked to breast cancer. And no.
Right.
And so many of the medications that are handed out like candy these days to anyone who wants them, even off-label, we don't have conclusive proof that
it does
not cause breast cancer.
Anything for that matter, right?
We have more proof that hormone therapy has not been conclusively linked to an increased risk of breast cancer than we have for those medications. And yet, those black box warnings just won't go away.
I know. And I mean, it even remains on some of the safest ones, like the vaginal estrogen. So, I mean, whenever I prescribe a vaginal estrogen for patients, I always say, please ignore the insert. You know, they just haven't been updated. And, you know, if you actually look at the monograph, it's not necessarily in the monograph, but it's just the packaging or the inserts. Like there's sometimes like a disconnect, right? Just in how things are rolled out and the time it takes for things to change. So, I mean, it is up to us to know and to educate patients that, like, you can trust what I'm doing. I'm providing, like, very evidence-based medicine. No, it's a big problem.
But it would be nice if we didn't have to fight the uphill battle. Although 100%. I do feel like when I started 5 years ago now doing menopause care, I felt like I was begging women to give hormone therapy a chance. And now I feel like I'm almost fighting them off.
Yes.
Like I'm spending more time explaining why someone may not benefit from hormone therapy. Are you getting a lot of people asking for testosterone? Can we talk about testosterone for a second?
Sure. Yeah.
Because that's having a moment.
Yeah, absolutely. There's a lot on social media about the benefits of testosterone in women.
What's your take on this?
I mean, so what we know is that it's certainly approved for the use of, like, hypoactive sexual dysfunction in women.
But off-label.
Yeah. But it will help.
Yes, it will help.
And I mean, I think clinicians probably are hesitant because it hasn't, like, been rolled out as to, like, what the best practice guideline is. But I do think that, like, I'm cautious about the claims that it's going to help this whole plethora of symptoms.
Yeah.
And I mean, women need to be, like, quite closely monitored when they're on testosterone. And so, you know, if it's happening in primary care and you have the opportunity to really, you know, work with women and monitor them and, you know that if we don't see an improvement in the symptom that we're chasing, then we shouldn't take it anymore, right? Like the risk-benefit analysis. But yeah, I think that, like, there's it's evolving, right? The case for testosterone.
Yeah, I think it's a good provider when they're asked about testosterone. We'll be very clear with you about the fact that it is good for certain things, namely hypoactive sexual desire disorder, and local testosterone can be great for pain with sex because there's testosterone receptors in the
and we have a
vagina.
Great medication for
we do. We'll touch on that too.
Yeah.
But they'll be honest with you about what we don't know. And they'll be honest with you about the potential side effects and the importance of monitoring. I monitor women relatively closely. Once we've established their dose, it's about every 6 months that I'll send them a blood requisition. And I'll chase them for their, they better get that result back to me if they want me to continue to prescribe.
Yeah.
Because it is the one hormone where the side effects can be irreversible and detrimental. Do you want to discuss the side effects?
Well, I mean, I'm familiar with the side effects because I do some trans care.
Yeah.
But yeah, we can see, like, changes in their voice. We can see redistribution of fat. We can definitely see, we want to make sure we're not putting anyone who's interested in preserving their fertility. But I mean, that wouldn't be this population necessarily. So, and often sometimes, like, those androgenic side effects, so hair growth and acne.
Mood changes.
Yeah.
Not in a good way.
Sometimes a little bit of a, like, ragey feeling.
Clitoromegaly.
That would be unfortunate too, or fortunate, depending on
if local testosterone is used appropriately to try to target sexual function and sensation, that's very different. But It's just something that I find a lot of the hype out there is touting the virtues of it without giving a balanced picture.
Yeah,
of
those
the
blanket
downside.
statements, everybody should be on testosterone, is just, this is what we're talking about. We need to
Exactly.
find a middle ground here. Not everyone should be on anything.
Yeah.
So,
Let's talk about the vaginal DHEA
sure.
suppositories.
Yeah.
Have you had a lot of experience and success using those?
Well, I think what's so crazy to see over the last 4 or 5 years as this new medication has come out, I was seeing OBGYNs actually we generally stay away from compounding medicines, right?
Sure.
As we know, evidence-based clinicians, really we should avoid compounding medicines unless it helps deliver the drug to a patient who can't otherwise take it the way it's made. So someone who has trouble swallowing, you might, create a liquid, what have you.
Exactly.
And for years, OBGYNs were creating DHEA vaginal suppositories, having them compounded. And then, of course, along comes a pharmaceutical company that's like, there's something here. So the DHEA suppositories, they're used nightly. They're, similar to what you might see with a rectal suppository for constipation. They look almost exactly the same. Or if you ever gave your child Tylenol up the bum, they look just like that. Put into the vagina nightly, and certainly can help with the normal symptoms of genital urinary syndrome, so the vaginal dryness. But then we think it might improve sexual function too. So.
Right. Because they convert to a little bit of testosterone as well as estrogen in the vagina. And then they're rapidly converted back to a non-hormone before they get into the bloodstream, which is what's so beautiful about them.
Yeah, so the systemic absorption of testosterone and estrogen is negligible. Yeah.
So have you had anyone complain that they're messy?
I've had, honestly, all of the vaginal things
That's true.
can be a little bit messy. Perhaps, I don't know.
I might just tell them, try to see if it works for you 5 nights a week or every other night. Just try to experiment a little bit with, if you're finding it's just too much discharge.
Yeah.
Maybe reduce the use a
and
little
you should
bit.
definitely put them in before bed as you're lying down for sleep, which also gives the case for having a nice long 7 to 9 hours of sleep.
Exactly.
Let that medicine just absorb over the time. But perhaps a little bit of discharge, can be seen with a lot of them.
Awesome. So if you have one parting message for primary care providers out there, it's maybe a difficult thing to summarize, but what's the message you just wish primary care providers who aren't providing menopause care would understand?
Well, I think the biggest take-home message is that primary care involves caring for people over the lifespan, right? And 50% of the population, if they live long enough, will go through menopause. And so, the care of women between ages 40 and 60 includes caring for them during the menopause transition. So what does that mean, right? So taking that preventative care lens of, making sure that women have all the tools that they need to get through this transition. It may not be hormone therapy. It may be just knowing that you understand where they are in the transition. I think primary care providers should be very familiar with the straw criteria, just knowing what the stages of reproductive aging are.
Yeah.
How, what changes do we see in these times? How long do they, on average, stay in these periods of time? And as their period changes, how can you counsel them about how to manage? So, I think, I don't know if the take-home message will have anything to do with therapy other than, try to have a few tools in your tool basket, 1 or 2 prescriptions that you're willing to start for women in each bucket. So in the menopause hormone therapy bucket, and then in the non-hormonal bucket, have a few that you'll try right off the bat, and then seek, care or assistance from a colleague that's more adequately trained and familiar. And my biggest take-home message is, please do not hesitate to give women vaginal estrogen.
Yes.
Of any age, right? It is a progressive condition. This is going to get worse over time. So if a woman comes to you for their cervical cancer screening and they have trouble getting the speculum in and they're in tons of pain, and lo and behold, they had 3 UTIs this year and they're not having sex with their partner anymore, that woman needs vaginal estrogen from now until the day she dies.
Yes.
And there couldn't be anything safer.
Nothing safer.
Please start your women on vaginal estrogen.
And I would just argue this could represent a massive time and cost savings if family doctors would learn about menopause.
Look at urosepsis. Like, we've got women that are being admitted with delirium
Yes.
because they have.
Yeah.
It's just such a shame.
It's a shame, but
Yeah.
that tide's changing too.
I think so.
Very excited.
me
Well,
too.
Jessie, thank you. This has been an amazing conversation. I want to thank Bayer, who made this possible through an unlimited education grant so that we could come together
Yeah.
as two menopause providers and provide everyone out there, women out there, with the tools, and maybe some providers out there with the tools to start addressing this. Thank you so much for being
Thank
on
you so much for
Medsplaining.
having me. It was my pleasure.
Thanks for listening. Don't forget to follow us on Instagram, Facebook, LinkedIn, and TikTok at Medsplaining. If you have any questions, shoot me a DM. And if you like this episode, the best thing you can do is tell a friend or rate and review it wherever you listen to your podcast so other women can discover it. And don't forget, if you're listening to this, you may be happy to know that we video every single episode, so you can watch it if you prefer on YouTube. See you next week. Medsplaining is produced by Ghost Bureau. Thank you for tuning in to Medsplaining. While we strive to provide accurate and insightful information, this podcast is not a substitute for professional medical advice, diagnosis, or treatment. The opinions expressed by our host and guests are their own and should not be interpreted as medical advice. Every individual's health situation is unique, and it is crucial to consult with a qualified healthcare provider regarding your specific concerns and conditions. Additionally, any links, resources, or references mentioned in our episodes are provided for informational purposes only and are not sponsored by Medsplaining. The producers and hosts of Medsplaining assume no responsibility or liability for any actions taken as a result of listening to our podcast. We encourage you to use the information presented here as a starting point for discussions with your healthcare provider. Information and references are subject to change based on scientific evidence as it evolves over time. The hosts and producers of Medsplaining are not responsible for future changes to the information and references and assume no obligation to update based on future developments. Remember, your health and well-being are paramount. Thank you for listening, and we look forward to exploring more topics in women's health with you in future episodes.